Hi, this is Dr. Cassidy here to review function and dysfunction related to the liver, gallbladder, and pancreas. Starting with the liver, all blood travels through the liver from the stomach and intestines through the hepatic portal veins, shown in purple. The liver also has hepatic arteries, shown in red, which deliver oxygenated blood from the heart. But the hepatic portal vein is where all blood passes through for detoxification and other liver functions. The liver produces bile, which is needed for fat absorption and digestion. Bile travels through the biliary ducts, shown in green, to the gallbladder for storage and to the common bile duct where it empties into the duodenum of the small intestines. The pancreas, shown behind the stomach, secretes enzymes to help with digestion. You may remember from the nutrition module that the enzyme protease helps with digestion of proteins, amylase helps with digestion of carbohydrates, and lipase helps with digestion of fats. All of those enzymes are secreted into the duodenum where the food needs to be digested. The pancreas also has endocrine functions. It synthesizes and secretes insulin for glucose to use to get into the cells where it can be metabolized. There are all other things that all of these organs do, but I'm only going to focus on the dysfunctions that you'll commonly see in acute care, except diabetes, which is covered in a separate module. The next two slides show many of the liver functions. I've colored ones related to acute care that we'll discuss in orange. The liver breaks down old RBC and WBCs for removal from the body. Remember, these cells don't live that long, and we are constantly making new ones, so the liver removes the old ones. The heme part of hemoglobin, which is the oxygen-carrying part of the red blood cell, is the only part that we're going to discuss because it involves an important function of the liver. Heme is broken down into bilirubin in the blood and then brought to the liver to be packaged for removal from the body. The liver also processes bacteria and other particles for removal from the body. The liver synthesizes clotting factors, bile, lipoproteins, albumin, and cholesterol. The liver also converts glucose to glycogen when there is an excess amount of glucose in the blood, and it converts glycogen back to glucose when there isn't enough glucose in the blood. Remember, glucose is the main energy source of the body. The liver also stores quite a few molecules, vitamins, minerals, and proteins, so the body will have them when they're needed. It also detoxifies drugs, toxins, and ammonia, the waste product of protein metabolism. Some of the ammonia is processed into urea for excretion in the urine, and some ammonia is removed in the stool. Dysfunction of the liver occurs in stages. Inflammation can be from viral infection, drugs, alcohol, or other toxins. When this happens, liver function can be acutely impaired. Fibrosis is like scar tissue forming from a continual damage to liver cells, hepatocytes. Fibrotic cells perform no function. Cirrhosis is extensive fibrosis that affects internal structures, including increased pressure on the portal vein, decreasing the diameter. The extensive fibrosis also means much less healthy cells for liver function, so there's overall dysfunction. This slide shows the different stages of hepatocyte injury. You don't have to memorize these. It's just to show you what a normal liver looks like compared to an inflamed or fibrotic liver. Once liver injury occurs, the fibrosis begins. The liver may enter into regression and return to a healthy liver if the caused agent is removed, such as abstaining from alcohol or taking medications to cure hepatitis. If the liver is not able to enter into regression, it will instead become cirrhotic, and from there it can lead to HCC, hepatocellular carcinoma. This table shows some of the liver functions, the opposing dysfunction, and then the symptoms associated with the dysfunction. The acute symptoms are important for nurses to know because you want to recognize when your patient is having a symptom and understand what it may be related to. Okay, let's start with bilirubin in the liver. As I said earlier, bilirubin is broken down heme that the liver packages for excretion in the stool. If there's dysfunction, it won't be able to remove all the bilirubin, so instead of it being in the stool, it will remain in the blood. Bilirubin is a yellowish color, and it's what makes our stool brown. So if it's not in the stool will be clay-colored instead. And if it's in excess in the blood, the skin, sclera, and mucous membranes will look yellow. That's jaundice. So if your patient has jaundice and or clay-colored stool, you're going to want to ask the provider to check a bilirubin level. Also, excess bilirubin can enter the urine and turn it brownish as well. The liver synthesizes and stores albumin. Albumin is a large molecule that plays a role in oncotic pressure. Without albumin, fluid will shift out of the hepatic circulation, the hepatic veins, and into the surrounding tissue, causing ascites. The liver also removes ammonia from the body. Ammonia, one of the waste products of protein metabolism, is toxic in high levels. So if the liver can't remove enough of it, patients will get hepatic encephalopathy, which causes confusion and lethargy and eventually death if not treated. The liver also metabolizes many of the medications patients take, and if it isn't able to do that, the medications remain in the blood longer, which causes, at higher levels, can become toxic. The liver also produces our clotting factors, and without them, there's a risk of bleeding. And the liver produces bile, which is needed for fat absorption and digestion. And without enough bile, some fat will pass through the GI system without being digested, causing steatorrhea, fatty stools. When the liver isn't able to convert excess glucose to glycogen for storage, the glucose levels rise, causing hyperglycemia, which we know over time is devastating to microvasculature. Also, the liver dysfunction, it won't as effectively convert glycogen back to glucose when needed. So if a patient is hypoglycemic, the liver won't be able to compensate, which can be very dangerous because patients can die from hypoglycemia. This is the gallbladder. It sits right next to the liver, and the biliary ducts move from the liver to the common bile duct to deliver bile when needed. Those ducts also go to the gallbladder to store bile, so it's always available when it senses fat in the intestines that needs to be digested. The gallbladder does two things. It stores bile, and it contracts to release bile when needed. Many people have gallbladder removed, a cholecystectomy. Then the liver just synthesizes and releases bile directly into the common bile duct, from there right to the small intestines. So bile is still available to help absorb and digest fat without the gallbladder, maybe just not as efficiently. Under dysfunction are three things that occur. Cholelithiasis is gallstones, cholecystitis is inflammation of the gallbladder, and cholangitis is inflammation of the biliary duct system. When the biliary duct is blocked, like from a gallstone, the bile doesn't get to the small intestines, fat isn't absorbed, so it passes through the GI system undigested and exits the body in the stool. The symptom would be steatorrhea, fatty stool. So when you see steatorrhea in your patient's stool, it can be from the liver not making bile or from the ducts being blocked, so bile can't get to the intestines. When the gallbladder senses fat, it contracts to expel bile. But if there's gallstones blocking the duct, it will continue to contract in an attempt to release the bile. This is very painful, and patients will complain of right upper quadrant pain with fatty meals. The pancreas sits under the liver next to the small intestines. The pancreatic ducts are where lipase, amylase, and protease are secreted into and brought to the small intestine. The pancreas has endocrine functions and exocrine functions, which we're focusing on. The exocrine functions already mentioned are the synthesis of the enzymes protease, lipase, and amylase. When a patient has pancreatitis, these enzymes leak out of the pancreas and actually start to digest the pancreas. The associated symptom is upper abdominal pain that can be extremely painful. Okay, these are my references, and this is how you can contact me with any questions.